All right. Hello, everybody. I just want to first off thank everybody for having me here for the privilege of being able to present this very important topic near and dear to my heart. And let's just get the ball rolling. Let's see, got a chat here. Perfect. Oh, okay. All right. So my name is Tom Kang. I'm a colorectal surgeon here. I just started here about 6 or 7 months ago, and I work in the Department of Surgery within the division of colorectal surgery. And I have no conflict of interest. So these are the topics that we're going to be discussing. Just want to really, each one of these topics can probably be its own kind of grand rounds, but just really want to touch briefly on the types of polyps and the tumor biology, as well as treatment options. And I have within the title slide and also here, I have in quotes the geriatric population. And while the surveillance and the treatment modalities can be pretty uniformly applied, I think within the geriatric population, we need to have really nuanced discussions. And I'll just talk briefly on anal cancers as well as future steps. So, as you may already know, colorectal cancer is extremely common. Depending on what you look at, it's usually in the top five most common cancers and also most common cancer-related deaths. And approximately 60% of our colorectal cancer patients are over the age of 70. And it becomes problematic when you try to kind of treat these patients because not only has rectal cancer treatment become extremely sophisticated, but when it comes to especially geriatric populations, they're not all homogeneous. It's a very heterogeneous group. So you look at not just the chronological age, but you also want to look at this thing called frailty. And I think, in my mind, it really kind of comes down to the patient's baseline functional status. And to me, the most important aspects of those are mental and physical. And obviously, the pathology is extremely important. So if a patient is in his or her 50s, however, is not mobile, has multiple comorbidities, probably not the best surgical candidate in comparison to somebody in his or her 70s who is active, is still driving, is traveling, gardening, doing all those things. And so for these reasons, again, assessing somebody's frailty to me is considered a better measure than looking at somebody's just age. Right. So cancer biology is an extremely interesting topic, at least to me. And it's been for many years just this hot topic because we now understand, not completely, but we understand better than before how this cancer biology can really affect somebody's prognosis and how we should approach it. And you can see here the different types of colorectal cancers that I listed. Obviously, adenocarcinoma by and far is the most common. However, there are other types, and as you go down the list, they're a little bit less common. So tumor progression, as you already know, it starts there. Most of the time they all start as polyps, and broadly there are two different types. We have the adenomas and also the serrated polyps. It's generally accepted that adenomas and serrated polyps progress to dysplasia and then subsequent malignancies through different pathways. So chromosomal instability is the pathway that the adenomas take, whereas methylation is what the serrated polyp pathway takes. And adenomas are the most common, contributing to about 90% of tumor origin. And you have listed here various screening options. Generally, colonoscopy is accepted as the gold standard. And in an average risk patient, you would start colonoscopy at age 45, so that this recommendation changed several years ago. And you have this fecal occult blood test, or there's a FIT test. So fecal occult blood test requires that the patient stays off of a certain diet and certain medications. Also, you require serial stool samples, whereas a FIT, it's specific, or you can screen for the human heme. Whereas a fecal occult blood test, if you had, say, like a rare steak 2 nights ago, it might come back positive. And then usually you want to kind of combine that with a flex sig, so yearly stool tests with every 5-year flex sig. There's a Cologuard, which is a FIT combined with tumor DNA. And then there's the virtual colonoscopy, or CT, or MRI colonography. Caveat to that test is that you still require a full bowel prep, and for polyps smaller than 10 millimeters, it's not as sensitive. And for historic context, I put here a double contrast enema. People don't really use that anymore, just because it's really the technique. You have to give the barium enema and then followed by an air enema, and the interpretation, obviously, the radiologist should be facile at interpreting those, and we're kind of losing that I guess expertise. So we don't really use that anymore. The caveat again to all these tests is that the colonoscopy is the route that you take if any of these comes back abnormal. Also, if you have a familial or kind of a genetic condition, you really don't qualify for any of these less invasive, I suppose, tests. You should really start with the colonoscopy. So now, what do you do with polyps? So management of any polyps during colonoscopy is very crucial, and I think it can be very challenging in our geriatric population, especially. So generally, the bigger the polyp is, the more malignant potential it has. So, for example, a 10 millimeter polyp has about a 20% chance of harboring a malignancy, and multiple endoscopic and pathologic findings contribute to how a polyp should be managed. So if you look here, the picture on the screen left demonstrates the gross appearance of polyps. So depending on how these pit patterns and look like, as you go down the list, there's a higher chance that it's going to be malignant. And then the picture on your right is it's called a Haggett classification of a malignant polyp, and by definition, a malignant polyp is a T1 lesion. So that means it's invading into submucosa. So if you look here, I don't know if you guys can see my pointer, but depending on where in this submucosal level the polyp or the cancer is invading, the management can be quite different. Okay. So what do you do now? So as mentioned previously, management of colorectal malignancy can come with nuances. You should really have a personalized discussion with every patient, but again, especially in the elderly population. So for example, an endoscopically resected polyp found to have high-grade dysplasia can be managed pretty differently. So if the endoscopic resection margin is, say, more than 2 millimeters, and the pathologist should not raise any concerns about the margin status. So if, say, you used a cautery to resect this polyp, then sometimes the margin status can become a little bit questionable. Also, the polyp itself should not be resected piecemeal. So if you see in the report, the endoscopist resected this thing piecemeal and it's high-grade dysplasia, then by definition, your margin status really can't be determined because they just took it, chunk by chunk. So really, ideally, you want to resect this en bloc. And so if these requirements are not met, then you really want to have the patient have a conversation with a colorectal surgeon about whether or not he or she would benefit from an oncologic segmental resection. For a malignant polyp, the requirements are about generally as above, but a few more. There's some other characteristics like tumor budding, lymphovascular or perineural invasion, submucosal, so the depth of invasion, as I showed you in the previous slide, how deep into the submucosa it goes. Because if it's a shallow tumor without any of the high-risk features, if you resected it en bloc, then potentially that patient has been treated of that colon cancer. So depending on the patient's functional status, you should have an informed discussion so that you can decide whether or not the patient would benefit from a repeat endoscopy in 3 to 6 months versus would the patient benefit from a radical resection. So referral to an appropriate provider would be pretty crucial here. An invasive cancer diagnosis should bring about a detailed discussion between the surgeon and the patient about the potential benefit of an operation versus the patient's life expectancy and current functional status. So just as an example, when I started here back in September, one of my first patients was a lady who was on dialysis. She was just not a very healthy lady, had heart issues, and she had a bleeding polyp that had brought her to our ICU about 2 months before I started. And she almost passed away from that because the bleeding was so severe. So really, and she just wasn't the healthiest individual. However, she and I had and her family, we were all involved in this very detailed discussion about the risks and benefit ratio of her undergoing an operation. Do we go in there and try to resect this endoscopically, risking a potential perforation, which could be a big deal for somebody like her, or do we, in a relatively elective setting, go in and just take out her right colon? That includes that bleeding, potentially malignant polyp there. So she actually ultimately ended up undergoing a radical resection. So I did a laparoscopic right hemicolectomy, and she stayed in the hospital for about a week. Initially, she was in the ICU because I just wanted to be ultra careful with how we were dialyzing her and all these things. And then she went out of the unit pretty shortly thereafter, and she's been doing great. And I think that's one of the beauties of working at a place like UAMS and an academic institution where we have multi-specialty providers, and we can really try to kind of do the things that maybe some of our community providers, community surgeons, may not be able to approach because of the risk stratification. All right, so the preoperative workup, you guys are all probably aware of all this. So once the patient is deemed a fit surgical candidate, you want to really start with the physical examination, get labs. You routinely get CEAs, CBC. I also get nutrition labs like pre-albumin and albumin. I also ask patients, have you been losing weight? Are your clothes still fitting nicely? Are they looser? Those things. And I remember to always ask about cardiopulmonary status. Any surgeries before, or any procedures, any blood thinners. Imaging includes CT, chest, abdomen, pelvis, and when it comes to rectal cancers, you want to locally stage them as well. And used to be that we would get endorectal ultrasounds, but nowadays we use MRI pelvis, unless they have some prohibitive factors like MRI incompatible pacemakers, or the patient has claustrophobia or something like that. And then there's this, let's see here, yeah. And then there's this thing called the frailty index. So the one on the left is a comprehensive geriatric assessment frailty index. And the one on the right is the calculator that comes out of the American College of Surgeons based on the NSQIP data. And admittedly, I have never used the CGA FI model, but I have used the ACS NSQIP calculator pretty frequently. And it's very nice because you can type in here next to the procedure in this box, the CPT code, and you just kind of go through all these check boxes, and it'll kind of spit out for you this huge page of bar graphs, and it'll tell you compared to the average, probability of such and such happening. For example, requiring a mobility assistance device or being discharged to a rehab. Compared to the average risk, this patient's risk is such and such, and it'll actually give you a quantifiable number. And I find that very helpful when you counsel patients on, hey, this is based on the data, this is kind of, where you're at. I think it really helps to guide the discussion and also to put some of these more abstract ideas into something more tangible for the patients. All right. So just to take a brief segue here, this study was published not too long ago. It's in August, and it's a pilot study actually. And the American College of Surgeons implemented 6 categories of pre and post-operative quality improvement measures, and they implemented these at 8 kind of pilot hospitals across the U.S. And the whole goal was to try to improve geriatric surgical outcomes. And their data suggested that just by implementing these 6 things, they were actually able to improve pre and post-op morbidity and mortality on our patients, or on their patients, I should say. And it just kind of goes to show you how important it is to have definable, actionable items. And when we really kind of stick to them, it's just kind of like an enhanced recovery protocol that we use so frequently. Early ambulation, early diet, all those things, Foley removal, and we can do a very similar thing for our geriatric patients. So this here, this picture is why I do what I do, and this is the exciting part for me. It's the operation. And as you may already know, we have a lot of different tools now to try to offer patients and really tailor even surgical therapy to what the patient's needs are. And if I can emphasize one thing for you, and if you can take one thing away from this talk, is to remember that no one surgical approach is the best approach. It can't be a universally applied thing. And it really needs to be tailored to the patient's comorbidities, pathology, what their needs are, and obviously obviously surgeon comfort level. And I have been fortunate enough to have been trained on all platforms, whether that be open, laparoscopic, robotic, and I feel very comfortable utilizing all 3. However, just because a surgeon can perform robotic operations, it doesn't really make that surgeon any superior or inferior to, say, somebody who does laparoscopic operations or just does open operations. I will kind of go into the importance of maybe keeping the incisions small to try to decrease the pain. However, really at the end of the day, what's important is, can you do the operation safely? Can you achieve the goal? And will the patient do for cancer? Will the patient have the optimal oncologic outcome? So I think those 3 things are what the important things, not necessarily like, can you do a robotic operation? Like, doesn't really matter. All right, so I have here 2 studies. The one in the left upper hand corner is the COST trial, and the one in the right lower corner there is the follow-up to that trial. So the COST trial is a landmark study that was published in the early 2000s, and it compared open and laparoscopic approaches to colectomy. So, at one point in our surgical history, there was a moratorium. Our American College of Colorectal Surgeons, our national society, put a moratorium on laparoscopic colectomies for cancers because the governing body just did not think that it was a safe approach. Now, the COST trial demonstrated that laparoscopic approach significantly decreases postoperative narcotic needs and also length of stay. And it also demonstrated that oncologic resection quality is not inferior. So notice I didn't say it's superior. It's not inferior to an open approach. And the follow-up study was published just a few years later, and it followed these patients enrolled in the study for about 5 years. And it noted that laparoscopic approach did not affect the patient's time to recurrence. Excuse me. And this study was published in 2018, and it shows that any major complication arising in the octogenarian population, within this study, the age spanned from 80 to 94 years, and it significantly affected the overall median survival. So the median survival was 66 months in patients without any complications, and just 13 months in those who experienced complications. And it really goes to show that any steps that can be taken to decrease such an event can benefit our geriatric patients. So kind of alluding back to that COST trial, narcotic use was decreased when you used smaller incisions. making sure that our patients, while they're inpatient, have any aids like glasses, hearing aids, dentures, making sure that their circadian rhythm is kept appropriate, open up the curtains, get them moving during the day, try to prevent delirium. So of which, pain can be a huge contributor to delirium. So I think all these things can really, make a difference, and they may seem small and patients don't necessarily think about it. And to be honest, sometimes I forget about it. And I think just to be cognizant of the additional needs that our geriatric populations can have while in the post-op period can be really helpful. So rectal cancer, what is the rectum? So the NCCN guideline defines the rectum as starting at the sacral promontory to the anal rectal ring. Generally, we say that the rectum is anywhere from 12 to 15 centimeters long. It's the it's kind of before the anus is the most terminal part of your hind gut. And anatomically, it's very unique. So it can both be intraperitoneal and extraperitoneal. So posteriorly, the peritoneal reflection comes up about 20 centimeters on the rectum. So the posterior rectum is essentially all extraperitoneal. Laterally, that peritoneal reflection comes up about 12-ish centimeters or so, and 12 to 15 centimeters, and anteriorly comes up about 10, 12 centimeters. So some part of the rectum is intraperitoneal anteriorly. So the implication of this anatomic consideration is tremendous, especially when it comes to different ways in approaching rectal cancer. So for example, if I performed a full thickness excision of a rectal cancer, like a local excision that was in the posterior rectum, then that means that the defect doesn't necessarily need to be even closed because it's all extraperitoneal. So the patient, I close them because that's just my practice, but even if it wasn't closed, the patient doesn't get sick from this because they're not leaking stool into their intraperitoneal cavity. And it also means that the rectum can be a structure that could be radiated because it's going to have a very minimal effect on the surrounding structures when the radiation oncologist targets that tumor within the rectum. So treatment approaches have changed drastically for rectal cancer. Used to be, kind of going back about a century or more, used to be that rectal and also actually sigmoid cancers too, they were viewed as very just kind of these dismal diseases for which there was no cure or treatment. And surgeons kind of surgical founding fathers would go in and just kind of take out these cancers without any consideration at all for any anatomic or embryological development. And there are clearly planes that we can follow to try to perform minimally morbid, minimally blood, kind of this bloodless operation. But there wasn't any of that. And now we know that there are certain principles that you need to follow when you're treating rectal cancer. And I tell patients about the three pillars of rectal cancer treatment. One is chemoradiation, 2 is systemic chemotherapy, and 3 is surgery, which is where I come in. And depending on the patient pathology and where the cancer is and the cancer biology, sometimes you can offer patients upfront surgery, but more frequently, because oftentimes these rectal cancers present at kind of a more advanced stage, you offer them a neoadjuvant treatment. Most often, we do at least a chemoradiation before proceeding to surgery. But nowadays, more recently, we've been employing this method called a total neoadjuvant therapy, or TNT. And that involves giving 2 of those 3 pillars up front, so the chemoradiation and the chemotherapy. And the order in which it's given, kind of defer that to the medical and the radiation oncologist. But all that to say, it's a very dynamic process because you can kind of give short course radiation, or you can give long course radiation. Will you give systemic chemo first? Will you give systemic chemo later? And you really need to have these multidisciplinary conversations to hopefully offer patients the most personalized treatment for them. Let's see. So yeah, this paper here listed by Dr. Angelita Habergama. She's a Brazilian colorectal surgeon. Is one of the first papers to really demonstrate this concept of complete clinical response and the effect of chemoradiation on rectal cancer. So in her paper, about 30% of the patients had complete clinical response. So that means no endoscopic findings of residual disease, or on MRI or endorectal ultrasound, there's no signs of disease. 26% of all patients did not undergo any operation, and 38%, excuse me, of patients were able to undergo a sphincter preserving operation. So stemming from her paper, she really started this movement of what we call watch and wait. And we offer that protocol at high volume institution like ourselves. And I always inform patients that it is by no means the standard of care at this time. The standard of care is still to undergo surgery. However, again, this is where that nuanced discussion becomes so important, because it's an 80-year-old patient with a very low rectal cancer. And if that patient had a complete clinical response, if the alternative to watch and wait is an abdominal peritoneal resection, meaning he or she will live with a permanent colostomy, then if the patient is reliable, has good transportation and a good support system, which can be very challenging for some of our patients. They have to travel, sometimes 4, 5, 6 hours just to come see us. If they're reliable, then I feel okay about offering them watch and wait. Especially, again, if the patient's just this fragile 80-year-old, because proctectomy or taking out the rectum is not a small feat, and it takes a huge toll on the body, and it has implications when it comes to urinary and sexual function as well. And what I quote patients is that about 20 to 25% of the time, patients who undergo this neoadjuvant therapy will have a complete clinical response, and about a fifth, so about 20% of those patients will have recurrent disease, but rarely with metastatic spread. Some of the younger patients kind of elect to enroll in watch and wait, mostly because, again, it has implications for sexual and urinary function when we do a proctectomy. So I think for some of them, it's a little bit more appealing. So, these are some of the special circumstances. Lynch, attenuated FAP, serrated polyposis syndrome, or MUTYH associated polyposis, and obviously IBDs. So these are just here for just kind of thoroughness sake. The operations for Lynch syndrome patients who have rectal cancer remains the same. But however, if the patient has Lynch and has colorectal cancer, then colon cancer, then the treatment should be a total abdominal colectomy. So again, these are discussions that the patient should have regarding the risks and benefits of getting the entire colon out versus segmental resection. And Crohn's and ulcerative colitis, you know about the bimodal distribution of the IBDs, and so some of our elderly patients do get diagnosed with IBDs a little bit later in their lives, and ideally you can manage them with medications, but if surgery is required, I usually prefer that it's the last resort for them. Oh, something's not working. Sorry. There you go. So adjuvant therapy for stage 1 colorectal cancers, the guidelines very clear. You don't really need to do adjuvant therapy. In fact, for surveillance, we don't even get imaging or CEA. We just offer them a surveillance colonoscopy. For stage 2, depending on what the tumor biology and shows, it's kind of a gray area, and I really defer that conversation to the medical oncologist and the patient, because some patients may benefit from additional chemo, some patients may not. And stage 3, it's very obvious, it's nodal disease. We do offer them chemotherapy. So the first study listed here is an article from, let me see here, sorry. So, 1 second, so I think I have the slides mixed up, I apologize. So the study, sorry, the studies listed here, we're talking about an overview of locally advanced rectal cancers in the elderly population. And the authors looked at more than 21,000 patients in the SEER database, and every 5-year increase in an age greater than 70 years was associated with a relative risk increase in 37% in cancer-related mortality and fewer cancer-directed surgeries, as well as less use of radiation. In addition, age greater than 70 demonstrated a 31% increase in cancer-specific mortality. So the authors actually suggested a potential undertreatment in the elderly. There was another SEER database study including over 4,000 patients older than 75 with locally advanced cancer. And it showed that the best cancer-specific survival outcome was in the neoadjuvant radiation group. A Mayo Clinic study demonstrated a survival benefit for elderly patients with clinical stage 3 rectal cancer. And with regards to the operative approaches, the patients over the age of 70 had a decrease in radical operations and more trend towards local excisions. And a different SEER database study looking at the elderly undergoing proctectomy demonstrated a better overall survival in those who underwent radical resections. And there was kind of something that was interesting was when evaluating the impact of TME, or the total mesorectal excision. That's when we follow the embryological plane when we do these rectal cancer resections. In the elderly population, the surgical technique did not improve survival compared to younger patients, and mortality within 6 months post-op was significantly higher in patients over 75 compared to a younger cohort. So with regards to all this data, I think we really need to consider several things. Just look at the studies kind of critically. In the elderly patients, we mentioned that they're a heterogeneous group, and I think it can really contribute to intra and or postoperative outcomes that may not be common in our younger patients. And we know that TME is what really ultimately leads to less blood loss, and also it contributes to a decrease in local recurrence. So TME in and of itself, I don't think is what probably contributed to the elderly population's mortality. I think rather maybe the pre-existing comorbidities, say like dementia or functional debility, or cardiovascular disease, that probably might have contributed to that outcome. And I think all the other stuff kind of makes sense, trending more towards local excision. There's definitely a selection bias, right, in some of these studies. All right. So I just want to take this moment real quick to kind of take another segue to talk about the employment of multidisciplinary care in cancer care. So MDT, or multidisciplinary tumor board, was conceived actually in our country, in the States, in the 70s as an educational forum. And it really developed into what's today a comprehensive, consolidated care for oncology patients. In certain countries throughout Europe, nationwide MDT implementation is already in place. In the US, there's a recent American College of Surgeons initiative to increase the quality of rectal cancer care. It's called NAPRC. I know at our institution, we're currently working towards COC, or Committee on Cancer designation. And after that, I'm hoping that we can also get the NAPRC, designation. There's really no great evidence that demonstrates a direct relationship between MDT and improved outcomes. There's just no, randomized controlled trial or anything like that. However, the data does exist to demonstrate a more accurate staging. There's a more frequent utilization of MRI, which we know is essentially kind of the gold standard for local staging, and a more thorough TNM staging when patients are presented with an MDT. And it's also an independent predictor for appropriate neoadjuvant radiation, even when you control for comorbidities and age. So in Europe, studies have demonstrated rectal cancer specific outcomes are equal or better than colon cancer outcomes within this MDT structure. So when I was doing my fellowship at UAB, every Wednesday we would have our multidisciplinary tumor board, and we would bring in patients and have surgeons, pathologists, social work, radiation oncologists, medical oncologists, everybody involved, radiologists, to discuss every patient and to come up with a individualized cancer care plan for these patients. And it was really for anal cancer and rectal cancer patients. And because just like at UAMS, these patients would have to travel a few, if not several hours to come to see us, we would formulate these plans and communicate those plans to the local providers, so that, because radiation treatment, for example, requires that the patient go to the radiation oncologist every single day, 5 days a week, for treatment, or anywhere from, if it's short course, 5 days, to if it's long course, for 5 weeks. And to travel, a few hours to do that every single day, that's just not feasible for a lot of them, right? So, and I think we should also employ something like that here, in a more structured manner. And that is definitely something that I'm working towards. And I think having this dedicated multidisciplinary tumor board will really address a disease that's as complicated as rectal cancer. And I hope I was able to kind of convey that to you throughout this presentation. And it'll really benefit everybody involved, because I learned so much throughout this, and I learned about different disciplines through the MDT. And ultimately, again, at the end of the day, this is why we're in this business, is to for the betterment of our patients. So I will kind of briefly talk about anal squamous cell cancer. It's so you can see this diagram here that demonstrates the anatomy of the anal canal and the distal rectum there. And we know that anal squamous cell cancers develop from dysplastic lesions that stem from HPV or human papillomavirus. We know that there are certain high-risk strains like 16, 18, 31, 33 that can predispose you to forming these anal cancers. This Dr. Norman Nigro was a surgeon at Wayne State in Detroit, a colorectal surgeon who had, I believe, a case series of about 7 people. And he employed this chemoradiation regimen, and 100% of all of them had a complete clinical response. And now that has become the standard of care, whereas before, what we would offer them is an abdominal peritoneal resection. And I quote patients about an 85% complete clinical response rate. And, for the most part, patients do pretty darn well with this treatment. So if the alternative is a permanent colostomy, I think this sounds very appealing to our patients. So this is just to kind of try to sum it all up. We have all these different factors that we can consider when we meet our patients for the first time for preoperative appointments, and also it guides at least my decision when I try to see what the best operative approach would be for intraoperative and postoperative outcomes. And also surveillance is just so crucial when it comes to colorectal cancer. All right, so in summary, colorectal malignancies are very common in the elderly. It's common everywhere, but it's very common in the elderly, especially in our aging population. And there are certain special considerations that I think our patients deserve, because if grandma if her main goal in life is to, say, travel or to go see her grandchildren, then is putting her through a radical proctectomy or radical resection of the colon, or just to do an oncologic resection, is that really the best approach? Or can we maybe try a less invasive approach, like a local resection or just a segmental resection rather than oncologic resection? And I strongly believe that rectal cancer and anal cancer should ideally be managed in a multidisciplinary fashion. So that is all I have. And if you have any questions, I would be glad to answer them. Oh, type 3. What's this mean? Oh, so the question was, if a patient has been diagnosed with type 3, I wonder if the the audience maybe meant stage 3. But anyway, low rectal cancer, does this mean the tumor is less or greater than 6 centimeters? Yeah. So the tumor, so the rectum, as we said, is anywhere from 12 to 15 centimeters. So if it's usually about I'd say so at the anal rectal ring, right? So that if we say that that's 0 to about, I'd say about 5 to 7 centimeters, I would consider that a low rectal cancer. And then from there to about 12 centimeters, there'd be a mid rectal cancer, and the upper rectal cancer is actually kind of treated more like a low sigmoid cancer. So 12 to 15 centimeters, I would consider that a high rectal cancer. I hope that answers your question. Is Cologuard considered an acceptable replacement for patients hesitant / wanting to avoid colonoscopy, or nothing substitutes a colon? Yeah, that's a great question. So, so in an average risk patient, any of those less invasive modalities are acceptable. The caveat again is if the patient has, say, Lynch syndrome, right, or familial adenomatous polyposis, or FAP or something, then Cologuard really is not an option. It should be a colonoscopy. Also, if that patient's Cologuard were to come back positive, that again leads the pathway down to a colonoscopy anyway. And a Cologuard, if in an average risk patient, if Cologuard is negative, you should get that every 3 years. Whereas a colonoscopy in an average risk patient, if it's negative, it's every 10 years. So, I understand it's a lot easier to just send in your stool sample. But, I think some of the things that are not maybe communicated clearly from us to our patients is that you can use any one of these methods, but then if the patient comes in saying, oh, my brother had colon cancer, and so did my mom, or, and then you offer that patient Cologuard, that is not appropriate. All right, so let's see. More along the same lines. 1, colonoscopy, the CR colorectal cancer screening tool of choice for most primary care providers due to the 10-year timeline. However, there's a serious shortage. Yes, I agree with that. Facilities / physicians who perform colonoscopies, leading to long wait times. So stool-based studies can be used effectively for patients who are average risk. Yes, I agree with that. Can PCPs feel confident in offering stool-based screening for 45, 75 years old, average risk patients? This allows for colonoscopy to be more available for high risk. Yes, yeah. So I think, right, so we're just kind of limited by our resources, as you're very well aware, I'm sure. So if, yes, in an average risk patient, any one of those methods, is acceptable. Strangely enough, flexible sigmoidoscopy is the only kind of screening method that was tested in a randomized controlled trial that demonstrated improved survival. So like any of these screening tests, in and of themselves, they've never been like compared head to head, right? However, we just know that having an average risk patient undergo those substitutes, I guess, for a colonoscopy can be acceptable. Whereas, as you mentioned, a high risk patient is probably not appropriate, right? So when PCPs receive the diagnostic report from GI performing the colonoscopy indicating cancer, do you recommend sending the patient to an oncologist or a surgeon for consult, or both? Trying not to sound too biased here, but I think so. Colorectal cancer, well, for rectal cancer, it's becoming a little bit different now, right? Because we mentioned this watch and wait. And I think a referral to a surgeon should be, in my opinion, should come first and foremost. Sometimes, so I'll give you an example. So I had a rectal cancer patient whom I saw one day after she finished her long course chemoradiation therapy. Now, I'm not saying that she underwent an inappropriate treatment, because I would have suggested, yes, she undergo chemoradiation. However, from a surgeon's perspective, it's very important for me to see, one, initially how this cancer looks like. Exactly where is it from the anal verge, from the anus? Can I offer this patient a sphincter preserving operation? Is the tumor invading the pelvic floor, right? Where is it? Is it posterior, lateral? Is it anterior? So these things I need to consider if and when the patient gets to surgery, but it is not necessarily the first and kind of foremost thing that oncologists, radiation and medical oncologists think about, because they're not ultimately the ones who have to offer the patient an operation. And that just stems from the difference in our training, right? Like, we're just in different disciplines. So I think referring that patient to a surgeon it takes priority. And then from there, for me anyway, like, I direct that patient to the radiation oncologist, medical oncologist, whatever the patient needs. What do you or would you offer to the patient who has fear of colonoscopy being too invasive? There's always, yeah. So I counsel patients on the risk of, bleeding if I were to biopsy something. There's a risk of, there's a less than a 0.05% chance, according to literature, risk of the colonoscope perforating the bowel. There's also rarely instances of splenic injury when you're kind of trying to get past a splenic flexure. So if it's an average risk patient, I would offer that patient, in line with the other questions, just some of the alternatives: Cologuard, FIT, FlexSig, virtual colonoscopy, whatever. But if the patient is not average risk, really that patient should undergo colonoscopy. And there's no free lunch, is what I always tell patients, right? So you try to inform them the best you can and help them make an educated decision. And if they're too fearful of whatever complications, then okay, well, the complication of undergoing a less invasive test might be that we miss cancer. So you just have to kind of make sure that they understand that. What will be the next preventative measure if the patient has completed an 8-week chemotherapy and the chemo does not work and the family has a high risk of cancer? If you could please clarify that question. I guess I don't really understand. Preventative measure after finishing chemo. So, like, I guess I don't really understand the context, I guess. Like, is a patient undergoing neoadjuvant therapy? Is a patient undergoing adjuvant therapy? And the family has a high risk of cancer. I guess I don't really understand that part either. Okay, thank you. Is there any hope for the patient with stage 4 rectal cancer and the odds to beat it? Yeah, that is a tough question, right? So used to be, as you know, stage 4 colorectal cancers, it was just like a death sentence, right? However, we have some data to support that if it's an oligometastatic disease, so if it's just like, say, one spot in the lung, or like one spot in the liver, right? Then you can also offer them metastasectomy, so you can resect the metastatic disease as well as the primary. And when those patients, we quote them, up to about 40 to 50% chance of 5-year survival. So it's better than, so in all comers, stage 4 disease, 5-year survival is, like 10, 20%. So it's better than that number, but it's obviously not like, say, stage 1 disease where the survival is 90+%. And it also depends a lot on cancer biology. So going back to the Lynch syndrome, if the patient has what we call MMR deficient disease, so we always test these colorectal cancers for protein expressions. There are 4 of them. And if there's a lack of those proteins, then we do a germline testing to see if they have Lynch syndrome, right? And if the patient has Lynch syndrome and metastatic disease, then they can potentially be qualified for immunotherapy. And there was a study that came out of Memorial Sloan Kettering in rectal cancer patients who were MMR deficient, and they gave those patients immunotherapy, and all of them responded. I'm sure you guys might have seen that in the news. So like the cancer just went away. So in stage 4 colorectal cancer patients who are MMR deficient, who have Lynch syndrome, we do offer them immunotherapy, and that could maybe help them. What would you caution PCPs to be on the lookout for? Signs/symptoms of CRC, anemia, abdominal pain, weight loss, what are the most common signs? Yeah, good question. So all those are signs. Most commonly, blood per rectum, changes in stool caliber. So the cancers on the right side are kind of more likely to bleed. On the left side, you can see, as the cancer actually left side, you bleed, and the right side as the cancer gets bigger because the lumen is bigger, so they can tolerate, I guess, more stricturing, right, from the cancer. So stool caliber changes, right? So those are kind of the things I look for. Weight loss, definitely. If you can't eat, you lose weight. With low rectal cancers that are invading the pelvic floor or the anal sphincter, patients can also present with dyschezia as well. They're just like, I hurt, my pelvic, my butt hurts, And I think, when they say like painless bleeding per rectum, especially if it's like a younger patient, there's data to say that some of those patients don't get diagnosed with cancer for up to 2 years because the suspicion is so low. And so, I think when patients present, and we're seeing a rise in this colon rectal cancer patients in the younger population. And so I think this index of suspicion should remain really high when anybody comes in saying like, I'm having blood per rectum. Like, you examine them and they have hemorrhoids. Sure, it could be from the hemorrhoids, but could it be from something more proximal? Yes, 100%, of course. So they should also be referred for a colonoscopy. Yes. Sorry for miscommunication. I'm curious if you would recommend adjuvant therapy following the 8 weeks of chemotherapy if it did not work. So I guess maybe what you mean is like, would I recommend additional chemotherapy if 8 weeks of chemotherapy did not work? So please correct me if I'm wrong, but I'm taking your question as the patient had surgery, had adjuvant chemotherapy, and if that did not work, would I recommend more chemotherapy? It depends on a few things. Again, first and foremost, it comes down to the patient physiology and cancer biology. Like, is the patient able to tolerate more chemotherapy? Because it's not an easy feat, it's toxic stuff that we're giving them. And has there been a progression of disease on surveillance imaging? After you finish, so 8 weeks would be 8 weeks would be 4 cycles. So after you finish that, you restage them. Has there been a progression? Do we need to change up therapy? So these are very kind of nuanced discussions that I defer to our medical oncologists. In a setting, say, for example, if the adjuvant therapy is not working, then you either need to switch it up or counsel the patient and just let them know like, hey, your disease is just kind of too far gone or something, So it's a terrible conversation to have. But I think preserving the patient's dignity and the quality of life is something that we often forget about because we're fixers. We're just born fixers as physicians. And we want to do something about it because we see it. But that doesn't necessarily align with what the patient and the patient's family may consider more important to their lives. And I think in a setting like that, our palliative care colleagues can be tremendously helpful to really focus on what it means for them to maintain that quality of life. Oh, you're welcome. Why is there a significant rise in colorectal cancer? Yeah, that's a good question. So we think it's multifactorial. So in older patients, yeah, could there be genetic? Yeah, sure, but most often it's kind of this sporadic thing. You get old, so kind of a background on that would be the usual transit time, right, from when you eat something for it to go through all 20 feet of your small bowel is about 2, maybe up to 4 hours. Kind of 4 hours is kind of the upper limit of normal. The transit time within the colon is about 40 to 50 hours. So that's why we think colon cancer, colorectal cancer are so common, right? And all that to say, so it makes sense as you age, you have this stool that's been sitting in there for 50, 60 years of your life, 40 years of your life, whatever. And you start to develop abnormalities. Now, in younger patients, it's a little bit different. We think that there's more of this epigenetic, possibly syndromic things that might be contributing to the rise in the cancer. Could be environmental. We don't know yet. There's no one thing that says that's the root cause of why they're getting this. It's a constant topic of study, and unfortunately, I'm sorry, I don't have a good answer for that. But we just know that there's been this trend of younger patients getting that. Some of our patients have been in their 20s, 30s, getting diagnosed with sometimes metastatic cancer. We know that in younger patients, the cancers tend to be more aggressive, and we don't know why. And it's unfortunate when you see those cases.